Okay, so as previously said, my name is Charles Martyn-Dickens. Just by way of disclosure, I am not a writer, and I'm very sorry for those who are disappointed by that. And I am very Ghanaian and not English. Okay, so today I'll be talking about comparative pharmacokinetics of Dolutegravir in children with HIV, with and without TB co-infection, using the WHO guidelines. I have no conflicts of interest to declare, and this work was supported by the National Institute of Allergy and Infectious Diseases of the NIH by R21 grant with institutional collaboration by the University of Florida Comparative Teaching Hospital, where I'm a pediatrician, and the Kwame Nkrumah University of Science and Technology. By way of introduction, we know that TB is a major cause of morbidity and mortality in children, but especially those with HIV co-infection. Children with HIV have an 8-fold higher risk of developing TB than those without HIV. Those with a co-infection have higher risk of death than those without HIV or TB. And though there are drug-drug interactions, ART is very essential to improve survival in children with HIV. WHO now recommends Dolutegravir-based ART as first and second line regimen for children with HIV, weighing at least 3 kilograms and 4 weeks of age, irrespective of TB co-infection status. DTG is metabolized by UDP glucuronidase transferase 1A1 and cytochrome P453A4. And rifampicin also is very essential for the short course first-line treatment due to its sterilizing activity. Rifampicin is a potent inducer of drug metabolizing enzymes stated above, and co-administration of both rifampicin and dolutegravir leads to reduction in DTG area under the curve and trough concentrations by 54 and 72% respectively. Dolutegravir 50 milligram given twice daily with rifampicin in healthy adults achieved area under the curve and trough concentrations that were a third and a fifth higher than those without rifampicin. Therefore, DTG twice daily has been found to be well tolerated and compensated for the induction effect of rifampicin in children and adolescents with HIV and TB co-infection in the Odyssey and empirical trials. And to the best of our knowledge, at the time of this study in 2021, there were no published studies on the comparison of DTG pharmacokinetics between children and adolescents with HIV with and without TB. So in this study, we compared the PK parameters and safety of dolutegravir twice daily in children and adolescents with HIV on RIF-containing anti-TB drugs, and then when they went off it, of the rifampicin whilst they were on DTG once daily. And then we compared it to the PK parameters in those not on TB drugs. So it was a prospective 2-period pharmacokinetics and safety study, and it was conducted in the Comparative Teaching Hospital in Kumasi, Ghana. Our study population were children and adolescents with HIV, with or without TB, weighing at least 20 kilograms, and previously naive to any of the integrase strand transfer inhibitors. At study entry, we took a complete medical history and physical examination and baseline laboratory tests, and we followed up at the first, third, and 6 months post-recruitment. Nationally, our regimen recommends that tenofovir, lamivudine, and dolutegravir at these doses if the patient weighed at least 30 kilograms, and abacavir, lamivudine, or zidovudine, lamivudine, fix those combinations with dolutegravir 50 milligrams if they weigh less than 30. And if you had co-infection with TB, you got a second dose of dolutegravir 50 milligram 12 hours later. For those with TB, 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol, and 4 months continuation of isoniazid and rifampicin. And this is a schema of the study design and endpoints, where our focus was on the PK parameters and the PK changes between the two groups. With regards to the demographics and some baseline labs, there was really no statistically significant difference in age, weight, and viral load at entry. Regarding the DTG concentration time profile in the two groups at first and second PK sampling, we realized that there really was no significant difference in the PK parameters of those with TB whilst they were on rifampicin-containing anti-TB medications. And when they went off, both seemed very effective. So PK parameters, as I stated, was not significantly different. We found the area under the curve and the trough concentrations were 93% and 69% higher in those co-infected while they were on BD treatment, BD dolutegravir dosing, compared to those who were off, who did not receive rifampicin. Rifampicin-based treatment increased DTG clearance, however, by 86%, but there was no significant difference between the two periods in those with tuberculosis co-infection. With regards to the geometric mean ratio and 95% confidence interval, this really showed no statistically significant difference. The only real observed difference was an increased clearance half-life of dolutegravir whilst they were on rifampicin-based treatment. So there was a trend towards increased DTG trough concentrations and area under the curve in the co-infected cohort whilst they were on BD dosing of dolutegravir compared to those who only had HIV and were on daily dolutegravir treatment. And the PK parameters were similar between the two groups in the second sampling period when those who were co-infected were now off rifampicin. None of the participants in the TB HIV co-infection group had the trough concentration less than 0.32 milligram per liter. So at 6 months of treatment on dolutegravir, 84.7% in the co-infected group compared to 72.3% in those with just HIV had that viral load less than 200 copies per ml. And there were no treatment discontinuation due to medication side effects. So in conclusion, the plasma dolutegravir exposure and trough concentrations were similar in both cohorts, treated according to the current WHO dosing guidelines. And twice daily dosing of dolutegravir compensated for the induction effect of rifampicin. And any revision of dolutegravir dose in children with HIV with TB co-infection during rifampicin-containing treatment will need to be supported by further studies. And would like to thank all the study participants and the supportive staff of the TB and HIV clinics at the Comparative Teaching Hospital. These are my references. Thank you.